Embryo transfer sounds like the grand finale of IVF, but today's rules are clearer and kinder than people think. Let me bust the big myths and give you a simple, updated guide in 3 minutes. Misconception number 1. Transferring 2 embryos will double my chances. Not exactly. Today, single embryo transfer is the choice for most patients under 38 with good quality blastocysts. Why? Because one healthy embryo gives high success with much lower risks of twins, premature birth, and complications. Twins are not a prize. They're a high-risk pregnancy. Misconception number 2. Fresh embryos are best. Actually, frozen-thawed embryo transfers often have similar or better outcomes than fresh, especially if your hormones spiked during stimulation or you need time to recover. Freezing lets your body reset, and the timing is precisely tuned to your uterus. Timing is everything. For programmed cycles, progesterone exposure is key. A day 5 blastocyst is usually transferred after about 5 full days of progesterone. What about a day 6 embryo? Many clinics will transfer closer to 6 days. Small changes, like even 12-24 hours, can change implantation rates. So stick to your clinic's schedule down to the hour. Technique matters too. Most modern transfers are ultrasound-guided, gentle, and quick. A soft catheter, minimal contact with the uterine fundus, no unnecessary manipulation, and yes, a comfortably full bladder, not bursting. What about supplements and rituals? There's no strong evidence that pineapple core, bed rest, or lucky socks change outcomes. Light activity is fine. Listen to your body. Now, mosaic embryos. This scares people, so let's simplify it. When you do PGTA, a few cells from the outer layer of the embryo are tested. Mosaic means that sample shows a mix. Some cells look chromosomally normal, some abnormal. Not all mosaic embryos are the same. Think of it as a spectrum. Low-level mosaic embryos, for example, under 20-50% abnormal cells, often have reasonable implantation rates and reported healthy baby outcomes. High-level mosaic embryos have lower rates, but not zero. The priority is usually normal embryos first, then low-level mosaic, then higher-level mosaic, always with informed consent. Importantly, PGTA tests a small biopsy sample, not the whole embryo. Embryos can self-correct, and the placenta is not the baby. That's why many doctors will consider transferring a low-level mosaic embryo if no normal embryos are available, especially in older patients or after many cycles. If you transfer a mosaic embryo, plan ahead. You'll likely have extra counseling, early detailed ultrasounds, and diagnostic prenatal testing like CVS or amniocentesis instead of just relying on NIPT. The goal is clarity, not worry. So, the guiding principles today are 1 healthy embryo at a time for most people, freezing when it helps with timing, progesterone precise to the minute, gentle, ultrasound-guided transfers. Mosaic doesn't mean fate, it means nuance. Ask your doctor about age, embryo quality, endometrial timing, and mosaic embryos. The best plan is the one tailored for you. You're not falling behind. You're getting informed.